Hi, everyone. Thanks so much for joining us for a special Ask the Experts Facebook Live Q&A. November is Lung Cancer Awareness Month, and we have two Moffitt experts here today answering your questions and sharing the latest on how Moffitt is using robotics in lung cancer care. Joining me are Dr. Eduardo Celis, a pulmonary and critical care specialist in the Department of Thoracic Oncology here at Moffitt Cancer Center, and Dr. Eric Toloza, cardiothoracic surgeon, also from our Department of Thoracic Oncology. Thank you both so much for being here. Before we get underway, just a few quick reminders for our audience. So please submit your questions in the comments section. We'll do our best to get to as many as possible. Now, please keep in mind, we cannot offer personal medical advice or make a diagnosis over Facebook. Additionally, Facebook is a public forum. Any comments and questions asked here are visible to the public. Now, with that out of the way, let's get underway here. Again, Dr. Celis, Dr. Toloza, thank you both so much for joining me.
Thank you.
Thank you for having us.
So we're using robotics here in two ways specifically. It's detecting and treating lung cancer. I want to start a little bit with the detection side. Dr. Celis, how are we using robotics to detect lung cancer?
Yeah, so basically robotics has come after a long technology of navigation, basically. This is one of the latest one that we have. And what we're using right now is to get to those small nodules. The nodules mean the small spots in the lungs. Those recently has been more found because of the lung cancer screening, that we have certain population that are at risk. So those are between 55 and 77-year-olds with certain history of smoking will go for lung cancer screening, get those spots in the lung, and that's how they get referred to us. That gives us the advantage of getting to those spots that we didn't have in the past. With more certainty and with higher yield of diagnosis.
Now, what actually happens during this robotic bronchoscopy process?
So from the beginning, is the patient gets referred to us, and they normally will have to get a kind of a little bit more high definition CAT scan of the chest, and this is to be able to create a map of the lungs. This creates a three-dimensional map that I would use to recreate the lung, so I can use a machine to go down to the lungs. The procedure itself will be done in the bronchoscopy suite that we have, and we use different technologies together with the robotic. One is ultrasound and the other one is X-ray. Once the patient is sedated and under anesthesia by our team anesthesiologists, then we will proceed. We go with this robotic arm that is very small. So we're talking about 1/6 of an inch thicker in terms of the catheter that we use. And we go inside the airways. The robotic that we use right now, it uses a control that's very similar to what, if anybody has a video games, it's very similar to an Xbox control. And we go down to the airways, and this allowed us to navigate and drive within the lungs. People have to imagine this as using the GPS in your car that you put the address and it takes you turn by turn. The same thing happens when we go inside of the lung.
And what is the training for that like? Are you a big video gamer? Do you have experience using that controller?
Both of them, actually. So I will have to say I still play video games. I still do that, but I also have my formal training. I'm not saying that anybody who is a video gamer can go on and do this. I've done my fellowship, and I have also extra training in interventional pulmonary. They also will train you on the side for the robotic. The company who does this robotic will take you and do a little course just to get familiar with the technology. But the main component is knowing the airways and physiology and pathology of the lungs. This is my background. So I've been doing this for many years.
Now, how does this new, these new robotic methods, how does that compare to the more traditional methods?
The yield is higher. So we have to look at this as two ways to get to the lesion. One will be how easy can I navigate to the lesion, and the second part is how good of samples I can get once I get to the spot that I want. So in the past, just to people get an idea, with the technology that we had before the bronchoscopy, the highest that we go in terms of yield and navigation was around 70% or so, 60 to 70%. Before navigation, when we used just X-ray or ultrasound, that was in the range between 40 and 60%. Now that we use robotics and navigation to the lesion, it ranged between 90 and 100% actually. And our yield to get a diagnosis from the spot is around between 80 and 90%. So it improved the chances of us going for more distant or more deeper lesion into the lung and a smaller lesion into the lung that in the past, sometimes because we didn't have the technology, the option was to either get with a needle from outside or just wait and repeat another CAT scan down the road.
And what patients qualify for this procedure?
Any patient that will qualify for a regular bronchoscopy will qualify for robotic bronchoscopy. So there is no specific criteria that somebody who will go for a regular bronchoscopy will not go for robotic. Obviously, we review every single case that it comes to us, and we decide if the procedure overall is indicated, either a regular bronchoscopy or robotic bronchoscopy. And once we review the case one by one, then we decide which patient will benefit from for robotic bronchoscopy or not.
Okay. And now, if I'm a patient, what should I expect if I'm going in for one of these?
The length of the procedure will be exactly the same, and we're talking about normally most of the times we get to the spot, and also we look at the lymph nodes that are structures that are around the airway. So we combine this procedure in one, and normally the procedure takes around 1 hour. So the way that this goes, as I say, initially they will get a high definition or a more high resolution CT. After that, we create the plan for the bronchoscopy. The patient comes the day of the procedure, normally an hour or so before the procedure, so they get prepared, get everything ready, all the information. After that, they move to the bronchoscopy suite. Then they will meet anesthesiologists over there. They will meet the rest of the team in there, and then they will receive sedation. They will fall asleep, and then we'll go with the procedure. The procedure, as I said, normally takes around 45 minutes, an hour. After the procedure is done, the patient will wake up, will go to the recovery area, and after that, we'll go home. So the advantage of all these bronchoscopies, specifically this robotic, is that it's outpatient. So the patient does not have to stay in the hospital. The overall, from the moment that they walk in to the moment that they walk out, is around 3 hours, 3 to 4 hours, depending on how fast the patient may wake up from the anesthesia. And that depends on a lot of other factors. But the bottom line is it's outpatient, and normally we get the results once we get the biopsies and tissue. Normally it takes around 3 to 5 days to get all the answers back.
Could you expand a little more on what you're actually looking for, when you're in there? You mentioned the nodules before. What do those look like, compared to healthy ones?
Yeah. So when we go down to the airways there, with this technology, actually, in a lot of cases, it let us actually look at the spot in the lung. In the past, because the thickness of the scope that we use, we were limited by the size of the airway. And then we'll have to just kind of go blind or use certain other techniques, fluoroscopy, or there is an X-ray or ultrasound, to try to confirm that we're in the lesion. Now with this technology, we actually sometimes can see the spot. We can, if you want to say, see the cancer directly face to face, and that increases our yield or our certainty that we are in the spot. So that is a huge advantage on this, and in the future, this technology, if it keeps moving forward, then not only will help us in terms of the diagnosis, to take samples from there, but also provide with some treatment, either in the form of energy, either like localized radiation, localized heat, or localized medication to the spot that we're looking down the scope that in the past, as I said, we were not able to see.
Now, can patients can they expect any pain or discomfort when they wake up from this?
Yeah, the normal thing that they will find is a little bit of sore throat, because we go through the windpipe. So we'll go for the vocal cords, is the voice box that everybody has in the neck. So there's always going to be a little bit of soreness in there. They may notice a little bit of blood in their phlegm, and that's normal. Normally that all the kind of pain, soreness, or any kind of other signs from the procedure goes away in the next day or two. The chances of any complication happening during this procedure are less than 2%. So very low with very high accuracy and yield to make a diagnosis. So a great technology that we have in our hands right now.
So is it fair to say that these are safer and more accurate than previous methods?
Definitely safer and more accurate. Help us a lot in terms of the diagnosis. Yes, for sure.
All right, thanks so much, Dr. Salsa. Again, if you're just joining us, our experts are answering your questions on robotic surgery for lung cancer. Be sure to post them in the comments below. And not just robotics, it's Lung Cancer Awareness Month, November. So any questions on lung cancer in general, we've got some great experts here to answer those for you. Dr. Toloza, I'd like to turn to you now, talking about treating lung cancer. So we've detected cancer in the lungs of these patients. How are we using robotics to treat that?
So besides the robotic bronchoscopy system that we use to diagnose lung cancer, as Dr. Celis described, we have a separate robotic surgical system that we use to remove lung cancers for cure. As this is a minimally invasive surgical approach, robotics is a way to allow lung resection through small incisions, typically 3, maybe 4 small incisions. And we don't need to divide major thoracic muscles like the latissimus or serratus muscles, which benefits the patients and allows less pain during the recovery period, less inflammation, and quicker recovery and return to normal activities. So robotics also benefits the surgeon as it provides a 3-dimensional view of the chest. As anyone has seen 3D movies, they're a lot more depth of perception than regular 2D movies. So the same thing in doing robotic surgery with the 3D vision. The instruments are wristed, so we're not doing surgery with just long sticks, where we actually have instruments that mimic how our hands and wrists work. The robot also scales the motion so that if I were to move an inch, the instruments only move about a quarter or less than half an inch, so it makes for more precise dissection. And the camera is stabilized as well as the instruments, and it's more comfortable for the surgeon, so they can work longer both during surgery and in their career. And these robotic features allows more precise dissection for improved and more accurate lymph node staging, which is important for treatment decision-making and prognosis, and also for improved dissection of the lung hilar structures like the blood vessels and the airway, which minimizes conversion to thoracotomy, which is the old-fashioned surgery with the big incisions.
And what can patients expect before going in for one of these procedures?
So if a patient is found to have a lung nodule, whether it's by lung cancer screening or incidentally because the patient got an X-ray or CAT scan for some other reason, and if this lung nodule is concerning for lung cancer, then one could get a biopsy for diagnosis and possibly also for staging, as Dr. Celis described. However, robotics will also allow for a surgical biopsy, which involves, again, those small incisions and taking out a small portion of the lung that has the nodule in it, what we call a wedge resection of the lung. And the pathologist can then look at the entire nodule, not just a small biopsy, but at the same time, the nodule is also removed. So whether it's benign or malignant, it's gone. And now robotics also allows for surgical staging of the lymph nodes in the chest, which again improves treatment decision-making because each stage of lung cancer has a different regimen of surgery in combination with chemo, with or without radiation. So it's very important to get really accurate staging, which robotics improves upon compared to the conventional thoracoscopic minimally invasive surgical procedure. And then prior to any surgical procedure, the patient needs to have staging studies, which would probably include a PET CT scan and either a brain MRI or CT scan of the head. We would also need to get pulmonary function testing to see how good the lungs are so that we know how much lung is safe to remove. We get pre-anesthesia testing, so meeting with an anesthesiologist to make sure a patient is safe for anesthesia, including blood tests, EKG, chest X-ray, and possibly a cardiac risk assessment and clearance by a cardiologist. And then we try to optimize the patient's nutritional status with protein supplements for several days prior to and continued after the surgical procedure. And then, of course, we'd get informed consent for the procedure and screen for resistant staph called MRSA, and also nowadays screen for COVID.
All right, very thorough there, Dr. Toloza. Thank you. We are starting to get some questions incoming from our audience. Jennifer asks, is genetic testing useful for lung cancer treatment?
So is that a question for both of us? I can start. So yes, there's different kinds of genetic testing. I think what the viewer may be asking is genetic testing like for breast cancer, is there a BRCA gene or something similar in lung cancer? We haven't really found a specific gene, but the genetic testing that we do actually tests the tumor DNA, looking for mutations and other markers that may offer the medical oncologist options to treat the patients besides chemotherapy. So options would be immunotherapy or targeted therapy against the mutations. There are also genetic testing looking for either gene or protein signatures in the patient that tells us if the patient is at high risk for recurrence, even if it's an early stage lung cancer, and also the chance that a nodule is a cancer, even if a biopsy says it's not.
Yeah, and to kind of this in the same lines with Dr. Toloza, and we check some of them, some of those tests, the protein marker for the patient to try to see if this is cancer, even if we have a non-diagnostic test. We do it during the bronchoscopy as well. It's done under a brushing, although lately they've been trying to come with some nasal swab as well. The part of the genetic, I think, also is part of the marker of the tumor. We can get it as well from the tissue that we get during bronchoscopy. Everything goes to the laboratory and help the oncologist, as Dr. Toloza said, to try to orient it or direct therapy on the patient.
We've got another question from a Facebook viewer, Ed. He asks, is PD-L1 testing done on any site at Moffitt? And how often after a biopsy is completed will tissue samples be sent off for comprehensive biomarker testing?
So for a surgical specimen, we usually have to wait at least 2 weeks after the surgery to do the comprehensive testing. And we've been doing that mainly for stage 2 through 3 and some stage 4 patients, again, to optimize treatment options besides just chemo. So PD-L1 refers to the marker for immunotherapy, but we also look at other things like microsatellite instability to see if a patient is a candidate for immunotherapy.
And the tissue can be always run if they have it still in laboratory, and this happens when the oncologist see the patient if this turns out to be cancer.
All right, another one, Dr. Toloza, this one is for you. Not a question, but viewer Paula says, thank you for saving her life 3 years ago. Oh, that's from Paula.
Thank you.
Another one for you, Dr. Toloza, going back to the robotic surgery. Can you just explain what are some of the risks and benefits of these procedures?
So first, the benefits of robotic surgery, as I mentioned, is the small incisions, improved lymph node dissection and staging, less need for a thoracotomy. The risks are pretty similar to those for conventional video-assisted thoracoscopic or VAT surgery and for traditional open lung surgery through a thoracotomy. However, one added factor is that during robotic surgery, the surgeon is not scrubbed at the OR table when the surgeon is doing surgery. They're actually sitting at a console that may be a few feet away from the operating table, typically in the same OR, so that if there were an urgent situation like bleeding that occurred from a major blood vessel that was not amenable to repair with the robot, then training and experience in robotic surgery, not just by the surgeon, but by the entire OR team, will help manage that event in a controlled and a safe manner. So it does require a dedicated OR team and of course a trained and experienced surgeon to perform this procedure, not just to do the procedure, but to manage unexpected events.
All right. And how have these kinds of surgeries evolved, over the past, say, 10 to 20 years? Yeah,
so robotic surgery has been around for a couple of decades now. The first robotic surgery was done in 1999. And over the years, there have been 4 generations of the robotic system. We have 3 of those 4th generation systems at the main campus on Magnolia at Moffitt, and 1 system over at the McKinley campus for some pelvic dissections. So we have 4 of these 4th generation systems. They've also been improvement in the robotic thoracoscopes over the years. So, just like TV monitors, those flat screens have gone from the original HD to now 4K. Same thing with the robotic thoracoscopes. There have been improvements in surgical instruments, in the stapling devices we use to cut the lung and the blood vessels, and of course, improvements in surgical techniques and the expertise by the surgeons and the OR team.
All right. And if you are just joining us, our experts are answering your questions on all things lung cancer for part of November and Lung Cancer Awareness Month, talking about robotic lung cancer surgery today. We've got a viewer question from Nancy. She asks, is this procedure recommended over Cyberknife or similar treatment?
So I'm going to tackle this one. So Cyberknife, even though it has the word knife, is actually a radiation treatment. It's not a surgical treatment. The reason that they have that name Cyberknife, or you may hear Gamma knife, is that the first such radiation machine was developed partly by a neurosurgeon, and they used it to treat brain tumors. And so they, just to make it fancy, instead of calling it radiation treatment, the surgeon said, well, we'll call it, radio surgery or something like that. And they put Cyberknife or Gamma knife. So radiation, so we call it here by the generic name, that type of radiation. It's called stereotactic body radiation therapy, or SBRT for short. That's like calling soda pop instead of Coca-Cola or Pepsi-Cola. So it's just a brand. So this is different, of course. So SBRT can treat the lung cancer nodule, but does not stage the lung cancer. So they're not biopsying any lymph nodes. And with radiation, the tumor stays in the lung. It's not removed. So you just, hope that it's dead, but then you have to do CAT scans every 3 or 4 months to make sure that it doesn't start growing again. The radiation oncologist quote a 90%, sometimes 80%, depending on the size and location of the tumor, 90% cure for lung nodules using SBRT or Cyberknife or Gamma knife. But obviously that's not 100%, right? So there's 10% chance that the tumor still is alive and will start growing. Whereas with surgery, if the tumor can be resected, it's gone, right? The hope is that it hasn't spread, and that's what the CAT scans are for.
Now, with Lung Cancer Awareness Month, I think it's important that we touch a little bit on the topic of smoking. For a long time, lung cancer has always kind of been considered a smoker's disease, but in recent years, we've seen a rise in cases in non-smokers. Dr. Celis, when you're doing these screenings, what do you see in the smoking versus non-smoking population?
Well, if we're talking about screening, there is a specific definition for patients that will go for lung cancer screening. And we're talking about low-dose CAT scans. So by that definition, the population that you're looking at is the patient that has a history of smoking. So we're talking about those have been smoking, it's called 30 pack a year. So basically that's the amount of packs per day that you smoke per multiplied by the number of years that you have smoked. So if you smoke half a pack a year for 50 years, then your history is 25 pack a year. So anybody who that number is more than 30, that will be the people who will go for a low dose CT of the chest. So that, by that definition, that population will always have a strong history of smoking. Now, you could have quit smoking more than 15 years, and then you will be out of that group. But we have to be aware that lung cancer is not only in patients that have smoked or have history of smoking. People that never smoke have also been seen to have cancer. And this, while smoking is one of the main factors for this, there are other environmental exposures that can give you cancer as well. The best known out there is asbestos, although there is other fumes, other chemicals that will be out there that will give you the chance of having cancer. The other part that people have to understand, there is not only one lung cancer. So there is different type of lung cancer. The big groups that are out there is the non-small and small cell lung cancer. The non-small cell has divided many of them. The ones that are more common, the non-smoker people, are going to be the ones called adenocarcinoma, and the most common that are in smokers are the squamous cell. Doesn't mean that you cannot have one or the other if you're a smoker or not, but if you get a CAT scan, a spot in your lung, for, like Dr. Toloza said, for other reasons, you have some pain in the abdomen, get a CT and get a spot in the lung. We also have to see your family history and your exposures over the cigarette. That will kind of give us an idea if you're a risk or not. And then we can move forward any kind of procedure or intervention.
Now, Dr. Toloza, as a surgeon, you're getting an up-close inside look at people's lungs. What does a smoker's lungs look like, versus a never smoker?
So often they've got, a normal lung, say a lung from a child or a young adult, they're pink. And then as we get older, not just smokers, but people who are exposed to pollution and diesel smoke, the lungs start to turn black. And you've probably heard of black lung of coal miners who are exposed to coal dust, all the time, and their lungs are completely black. So we do see, these what used to be pink lungs start to turn black, not just on the surface, but within themselves.
The Federal Trade Commission recently published a report saying that cigarette sales are actually on the rise for the first time in 20 years. So they've gone down every year for 20 years in a row, except for in 2020. Now, a lot of that is attributed to pandemic-related stress. But as somebody in lung cancer care, what's your reaction when you hear something like that?
I think we just need to reach out to the people, especially the younger people who have not yet started smoking or are thinking about it, or may have started, but haven't really developed a habit yet where they're addicted to the nicotine, and just reach out to them about the dangers, not just for lung cancer, but also head and neck cancer, and as well as other diseases like heart disease, atherosclerosis, and other health diseases.
Yeah,
Dr. Celis?
Yeah, it's definitely mind blowing. I think Dr. Toloza hit the spot. It's basically education and trying to reach and provide with information. Yes, the lung cancer will be there, but other things like worsening of asthma, COPD will start at the rise. So definitely the best advice is do not smoke. If you are already smoking, trying to reach for help. There is always help, even free. Doesn't have to be paid. There is several programs in North and other hospitals that provide with that to quit smoking.
Yeah. And the folks that may have restarted smoking after having quit for a while, and they restarted because of the pandemic and other stresses, we know that they can quit because they've done it before. So again, just reaching out to them, maybe finding ways to help with whatever stress put them back onto smoking cigarettes, and trying to get them to quit again.
On the topic of smoking, we've got a question from Facebook viewer Jennifer. She asks, how harmful is secondhand smoke?
Personally, I think it's just as harmful. Again, you're not getting filtered smoke. So the smoker, when they're smoking a cigarette, what they smoke, a lot of it is going through a filter, right? But what you get as a second smoke recipient, secondhand smoke, it's not being filtered. And if you're exposed in an enclosed space, like at home or at work, although at work it's less common now because of laws preventing that, then you're just as at risk as someone who smoked. In fact, here's a funny anecdote. This is back in the 80s. If you would fly, in an airline when people were smoking, they would usually reserve the frontmost rows and the backmost rows for smoking, right? Except there was this one Spanish airline where they allowed smoking on the right side of the plane, but not on the left side of the plane. And that always struck me as kind of funny how they could separate the smoke on one half of the plane.
Yeah, and the secondhand smoking, the one of the challenge in there is to try to quantify it and make it objective, right? So when you have somebody who has smoked or is still smoking, you can tell, as I said, how many packs of cigarettes are you smoking? How do you quantify how much of the secondhand smoke have you been exposed to? And that's always kind of difficult. And then this is kind of also a funny story, funny or interesting story. I have a patient that had lung cancer, smoked probably like 2-3 packs a day. The cat that lived with the patient died of lung cancer as well for secondhand smoking. I will have to assume because there was no other risk factor, but even the cat got cancer.
You mentioned the phrase earlier, pack years, referring to cigarettes and how much you smoke. Tampa, is known as Cigar City. How do we measure cigar smoking versus cigarette smoking? Is there a way?
There is no specific way for that. Again, this is you can try to measure how many cigars the patient is being smoking, but again, it's no translation into packs years like you will do with cigarettes.
And remember, cigars aren't filtered.
Right. That was my next question. I mean, what is that? Is it better because are there less chemicals in cigars, or is it worse? What's the difference?
It's the same, and it depends where it's coming, how it's being processed. So people have to understand that it's only not the tobacco and the nicotine that you may have in the cigar or cigarettes. It's also everything that comes into the paper, everything comes into the filling, the process, the colors, the flavors that they have. All that comes into the mix, and most of them are metals that will go down to your lungs and will expose to your lungs to something that they shouldn't be.
We've got a question from Facebook viewer Shirley. Won't get into too many of her specifics, but basically she's been smoking for a long time. Her parents smoked in the house, in the car. Is there any hope for her now?
Yes, there is always decreasing risk whenever you stop smoking and stop the exposure. Obviously, the degree of how your risk will lower will depend on the time and the complete removal of exposure. But yes, there is always you always try to tell the patient to quit smoking. It's better early than later.
And if you quit smoking, if the viewer is currently smoking, if they quit, they shouldn't see some improvement in their breathing in the next 2 to 4 weeks. But that staying off the cigarettes is the tough part because of the nicotine addiction.
Mm-hmm. Talking about quitting smoking, Carol, one of our viewers, asked, how successful is hypnosis when it comes to quitting smoking? What kind of things is Moffitt doing in this area?
I'm not quite sure about that, honestly. If they provide with hypnosis or any kind of related treatments on those lines, what is described in the literature, that is that education plus any kind of nicotine replacement therapy is what is being the biggest achievements. Hypnosis, unfortunately, I'm not aware of any specific research or numbers that I can give. I don't know if Dr. Toloza knows any of that.
I only know anecdotal in that it does help some patients.
The FDA recently approved its first, e-cigarette product. What is Moffitt's stance, when it comes to using e-cigarettes as a way to quit cigarette smoking?
Eduardo?
Yeah, there's this very debatable in there, and I think there is this. I see it as a double-edged sword in there, because if your intention is to try to quit smoking, unfortunately, they also been different studies I've seen that people who start on vaping or e-cigarettes may end up just hooking up into that and continue that, or if they're by de novo, because somebody, especially young people that start with e-cigarettes and vaping, may transform into smoking cigarettes. So the way I see it is a very tricky situation if you're trying to get off cigarettes by using an e-cigarettes, vaping, or any of those. I would recommend trying to go with education and nicotine replacement therapy and completely stay away from anything that will bring anything other than air down to your lungs.
Yeah. So the other problem with those e-cigarettes is that they're loaded with a nicotine solution, right? So it's very easy to overdose on the nicotine with the e-cigs and vapes compared to the nicotine in cigarettes that, you're only allowed so much depending on how much the tobacco is burning and how much you inhale. But with the e-cigs, if you overdose, you essentially can have a heart attack. You can have arrhythmias and high blood pressure, things that the nicotine will cause if you have too high of a dose. The other thing is also filled with heavy metals, as Dr. Celis mentioned during the cigar discussion, and those can cause other damage to the lung besides cancer. You can get pulmonary fibrosis and other heavy metal damage to the lungs. So as Dr. Celis mentioned, the e-cigs are not really meant as a replacement for cigarettes. They can be used potentially as a tool to get off cigarette smoking, but the goal is to get off the e-cigs as well, not just replace tobacco cigarettes.
Looks like we've got one more question from our viewers here. Ed wants to know, is Moffitt doing anything to get the criteria for low-dose CT scanning broadened any more than we were earlier this year?
Yes. So we've lowered the pack year requirement. It used to be 30 pack years, which is what the NSLT study suggested. So we've dropped it down to 20 pack years. And there used to be a limit on how many years since quit smoking, but we eliminated that completely. And we broadened the age. So it used to be 55 to 74. And now it's for 50 years or older. So 50 years or older, 20 pack years, and any status of quitting.
Do you see that criteria expanding even further in the future?
Perhaps. We don't know.
Okay. Put you on the spot a little bit there.
Yeah.
Another one from Jennifer. She asked, is there anything non-smokers can do to decrease their probability? Non-smoking lung cancer patients can do to decrease their probability of a recurrence?
So non-smoking patients, so there's two things. One is their tumors tend to have mutation drivers that can be targeted with certain drugs that the oncologists have in their armamentarium. So being tested, having their tumors tested can do that. There's also a test now that, again, if it's an early stage cancer, meaning no lymph nodes involved, then we can run this test and see what the risk of recurrence is. And if there's a high risk, then we can then refer the patient to an oncologist to discuss having treatment, even though it's a stage 1 cancer. And then there are other research studies where a female non-smoker who has lung cancer can volunteer, and then we can maybe identify other factors that will either prevent or predict whether a patient will recur.
All right, looks like that's all the time and questions we have for today. Dr. Celis, Dr. Toloza, thank you so much for joining us, and everyone who joined in, submitted questions in the chat. Thank you so much for participating. And for more information on lung cancer, you can visit moffitt.org.
Thank you.